Poverty and poor health are inextricably linked worldwide. The causes for poor health in millions globally are rooted within factors such as political, social, and economic justices. Poverty is both the cause and consequence of poor health. Two basic approaches to poverty in sociological terms is in terms of structure and agency. If focus is shifted to the contemporary rather than historical approach, it becomes useful to situate the definition of poverty within the structure versus agency debate. As the slide identifies, there is a variety of factors that contribute towards poverty and health issues. These factors can include issues like education, environment, diet, economics, healthcare, and also social factors. There are four key specialists of poverty and health, the first being Sir Edward Chadwick. Sir Edward Chadwick was an English social reformer who was noted for reforming the Poor Laws and the improvement of sanitation and public health. Chadwick was later promoted to Chief Commissioner in 1883. In 1842, Chadwick successfully published reports on sanitary conditions of the labouring poor. In 1847, he went on to be appointed to the Committee of Inquiry into the Sanitary Conditions of London. In 1848, he became the first ever Commissioner on the Board of Health and also pressed for the Public Health Act in the same year. William Farr was a British epidemiologist and was regarded as one of the founders of medical statistics. In 1841, he was employed to handle data for the United Kingdom census. In 1849, during a significantly large cholera outbreak in London, Farr initially assumed this was an airborne disease following the miasmic theory. But later in 1866, following a second cholera outbreak, Farr agreed upon John Snow's theory that cholera was in fact carried by water and not by air as he first thought. John Snow was the founder of modern epidemiology and discovered that cholera was not an airborne disease. In 1854, he participated in the changes to create more efficient water and sewage systems in London. Finally, Benjamin Rowntree, who was an English sociological researcher, reformer, and industrialist. Rowntree conducted 3 York studies in poverty in 1899, 1935, and 1951. His results from his first study was published in 1901, and through the systematic studies, he composed a poverty line which gave the ability to discuss a borderline and created a line which, when an individual drops below, would mean that they were extremely poor or under the poverty line. And this leads us to the question, what is poverty? According to the World Bank Organization, poverty is hunger, a lack of shelter, being sick and not being able to see a doctor. Poverty is not having the access to school and not knowing how to read. Having a job and fearing for the future and living for one day at a time. Poverty has many faces, changing from place to place and across time. It has been described in many ways. Most often poverty is a situation people want to escape. It's a call to action, a call to change the world so that many more have enough to eat, adequate shelter, access to education and healthcare, protection from violence, and a voice in what happens in their communities. Statistics show that 1 in 5 people in the UK are living in poverty, and poverty is rooted within political, social, and economic injustices. Factors of this include where we live, the food we buy, and money available to us. These factors all contribute to a general lack of basic resources needed to support minimum needs. Poverty is a consequence of and also a link to poor health. In terms of more specific examples, poverty could be induced by issues such as overcrowded living, which may result in disease transfer, or the spreading of germs and viruses. Poverty could be a result of a lack of education, which may then affect access to further opportunities, including higher paid employment. This could then affect mental health, resulting in a feeling of helplessness, depression, anxiety, and these individuals would then stay beneath the breadline. A lack of education services could result in the poor not accepting vaccinations, and therefore resulting in the spread of disease, unemployed or low-wage individuals. People in unstable employment may also have limited access to provisions and facilities, including healthcare. Discrimination of the poor could further include and lead to segregation from society, which when linked to health would result in possible mental or physical health issues. Poor sanitation in poorer areas could cause disease to spread, just like the cholera outbreak in London. Finally, the poor and vulnerable may make poor choices which may affect their health and well-being, such as buying junk food and not a balanced diet, also the purchasing of alcohol and cigarettes. All these factors can be broken down into 2 key explanations of poverty, these being absolute and relative poverty. Absolute poverty is when a household income is significantly low, resulting in the inability to afford the basic needs of living,
including food, shelter, safe water supplies, education and healthcare. Even if a country has grown economically, this does not mean that the people below the breadline would be affected. A key example being India. This then continues to impact survival and the physical and mental well-being of the individual. On the other hand, relative poverty is where households receive 50% less than the average income. These households may have slightly higher income but are still unable to afford basics above the breadline, including any luxuries that a higher income household could easily afford. This is, however, a changing concept depending on economic growth. So as the economy grows, relative poverty does also. This is measured by identifying household incomes, and the top 5 to 10% earners are viewed against the bottom 5 to 10% of earners. Micro and macro levels are commonly used in sociological analysis and interlinked with health. Micro levels refer to social situations, for example, patient and doctors or other healthcare practitioners. This is the study of site interaction between patients and professionals and exists to analyse the meaning of these interactions. For example, inside a care home facility or within a hospital environment. This information has significant healthcare outcomes for the patient. The two theories associated with this level are symbolic interactionism and social psychology. Macro, however, gives a larger perspective, looking beyond the waiting room. It views larger factors such as ethnicity, race, sex and gender, and analyzes these areas. The macro level looks at material and cultural determinants and views mortality and morbidity rates. The macro level is highly important as many healthcare professionals may overlook this and not have a full understanding of its significance. Now on to the political perspective used in medical sociology. Last year, the National Health Service reached its 70-year anniversary. Founded in 1948, the NHS was created through the ideal that healthcare should be available to all regardless of their wealth and income. The NHS was launched by Aneurin Bevan, who had to successfully win the doctors' vote by offering them a generous wage. They would be compensated for the fact that their patients were now being granted their services for free. Bevan resigned in 1951 after the Chancellor of the Exchequer induced prescription charges, which was valued at 1 shilling per prescription and £1 for any dental charges. The NHS has now become a highly successful national institution. The Black Report was issued in 1980 under the Conservative government, but it was originally commissioned in 1977 under the Labour government. The Black Report was written by Sir Douglas Black, and this report questioned how healthcare was socially distributed. It suggested that the inequalities had in fact widened rather than diminished. Since the NHS was founded in 1948, it suggested that these inequalities were due to social inequalities, such as income, education, diet, employment, and work conditions. The findings were virtually disowned by the Secretary of State, and social services so minimal copies were ever printed. Spirit level or redistribution of wealth was a report published by Kate Pickett and Richard Wilkinson, and highlights the direct correlation between economically unequal societies and poor health. The report erodes trust and increases anxiety illnesses and encourages excessive consumption of drugs and alcohol. They argue that the vertical redistribution of wealth would rectify and improve the health of society. Each of the 11 health and social problems are included within this, including physical and mental health, education, imprisonment, obesity, social mobility, trust and community life, teenage pregnancy, violence, drug abuse, and child well-being. All of these issues will be targeted if the redistribution of wealth across all social classes. It is decided that outcomes were significantly worse in more unequal rich countries. Now on to factors of influence and the social distribution health chances. Starting with gender. Gender within this sector causes morbidity and mortality and is not straightforward like social class. Social class has a clearer relationship with poor health and mortality. Women statistically have a higher life expectancy than men because the female immune system is more robust. So this is a biological factor. There are inequalities in work resources, and especially within power positions. For example, we may gain a higher quality by women being in higher political and economic responsibility. And within areas of Europe, there are different roles and responsibilities of men and women, which affect health choices, such as in certain European countries, where men share the responsibilities equally, whereas in the UK, men are usually considered to be the breadwinner, therefore adding pressure to women and their health. Social class is a factor. There's a correlation between higher professionals and lower unskilled workers within social class, especially where the background of the husband's occupation is a sufficient role. The female has a statistically lower rate of dying young. Factors within this include education, living and working conditions, and access to health services. All these factors take effect when discussing social classes and factors within health.
Race and ethnicity is inclusive of different groups. Race provides a biological concept, whereas ethnicity is a cultural concept. Within this, there are a range of factors such as genetic and biological factors. If we look at Afro-Caribbeans, they have a higher rate of sickle cell anemia compared to white Europeans. Within migration, most individuals settle within urban inner-city areas, where there was already poverty and deprivation, creating social risks, and affecting access to healthcare. So due to poverty and insufficient education, this could create further issues, or it could be that the health promotion provided does not fit within the traditional patterns of their culture. If we examine all these factors, they all interlink. This is called intersectionality. Gibbons 2014 said that the interweaving of social inequalities, including class, race, ethnicity, gender, disability, and sexuality. This produces more complex patterns of discrimination than single-dimensional conceptualization allows for. This identifies the clear connections between all these factors. For example, with a Black working-class individual, when compared with these factors, would have two other social factors to contend with. We have now discussed the causes, factors, and links of poverty and health. Thank you for watching.